Thank you, Ashe. Good afternoon, everyone. My name is Ken DeSerci. I'm the Deputy Project Director for the National Quality Improvement Center for Collaborative Community Court Teams. And welcome and happy holidays. Everybody's in the home stretch between tidying up work before taking some holiday time off, as well as preparation for the holidays, family and friends and everything that goes with that. So we appreciate you taking the time today to join us for this webinar. If you're on the phone and you can't see the webinar slide, but you can't get into the webinar to the GoToWebinar site, you can call 714-505-3525. And as the commercial says, operators will be on standby to assist you. Now, our staff will be there to assist you and help you get connected to the webinar. So I'd like to welcome you to today's orientation webinar on the site with the National Quality Improvement Center for Collaborative Community Court Teams. For the sake of this presentation, we're going to refer to the National QIC as the QIC throughout the presentation. The National QIC is a program of the Administration on Children, Youth, and Families, the Children's Bureau. And we're implementing the QIC through a cooperative agreement with the Children's Bureau, which essentially means that our federal project officer, Tracy Watkins, who you'll meet in a few minutes, on behalf of the Children's Bureau, will be actively engaged in the development and implementation of the Quality Improvement Center. Today's agenda, let's highlight today's agenda. We have a short amount of time to cover a lot of information. We've kept this down to 60 minutes. And in addition to me presenting throughout this webinar, we also have several other presenters. So Terry Tobin, Dr. Terry Tobin, who's the director of the Center for Research and Evaluation and Advocates for Human Potential. And AHP is our evaluator for the National QIC. We'll be assisting the demonstration sites with participation in the evaluation as well as local evaluation. And then Tracy Watkins, a child welfare program specialist with the Children's Bureau and the Administration on Children, Youth, and Families. As I just mentioned, Tracy is the federal project officer for the QIC and kind of leading the work, our work, and through us, through the QIC team, leading your work as well. And with that, I'd like to turn it over to Tracy.
Thank you, Ken. Good afternoon and good morning, I believe. As Ken indicated, I am Tracy Watkins with the Children's Bureau, specifically in the Division of Program Innovation, and I am serving as the Federal Project Officer for the National Quality Improvement Center for Collaborative Community Court Teams. So just a few minutes on the background and intent of the QIC. The Children's Bureau recently awarded a discretionary grant through a cooperative agreement to the Center for Children and Family Futures to implement this QIC. The intent was to build on the work of the Quality Improvement Center infant toddler court teams to specifically address the needs of the infants, young children, and their parents or caregivers affected by substance use disorders. And specifically, we wanted to focus and carry out the structure which highlighted the importance of collaborative work with courts. The QIC support demonstration sites that establish or enhance collaborative community court teams to design, implement, and test approaches to meet the requirements of the Child Abuse Prevention and Treatment Act, or CAPTA, as amended by the Comprehensive Addiction and Treatment Act of 2016, or CARA, which of course is the comprehensive federal legislation enacted in 2016 to address the opioid epidemic. There are four key areas that CARA had an impact on CAPTA. And so those changes were, one, to further clarify the population to infants born with and affected by substance abuse or withdrawal symptoms resulting from prenatal drug exposure or a fetal alcohol spectrum disorder, specifically removing illegal, so that this would cover both illegal as well as legal substances. Two, require a plan of safe care to include needs of both infant and family or caregiver. 3, it specified data to be reported by states. So, for example, number of infants for whom a plan of safe care was developed, number of referrals made for services, etc. And lastly, it specified an increased monitoring and oversight for states to ensure that plans of safe care are implemented and that families have access to appropriate services. So given the rise of substance use disorder nationally and the increase in the number of infants and young children entering foster care, there is an acute need to enhance coordination across family-serving entities. As such, we are looking for demonstration sites to include intensive collaboration among the following agencies. A little later in the presentation, Ken will speak with you about this various pathways that you can enter into this program. One of them is through the state and tribal or government oversight, which would be led by the Court Improvement Program. And those teams should include members of the Child Welfare Agency, Substance Use Disorder Treatment Agencies, Public Health, either maternal and child health, and or tribal government consortia. Pathway 2 focuses on local level leadership. And again, we would be looking for the local court to be the lead on that and to also include members of the Child Welfare Agency, again, substance use disorder treatment and mental health providers, maternal and infant health care providers, hospitals, and attorneys. This list is not comprehensive and may include other important partners at both the state and local levels depending on your jurisdiction. Just quickly, I wanted to go over the goals that we hope to accomplish through this National Quality Improvement Center. Ultimately, of course, we want the implementation, which would be to enhance the capacity of the court teams to appropriately implement the provisions of the Comprehensive Addiction and Recovery Act, or CARA, amendments to the Child Abuse and Prevention Treatment Act, or CAPTA. We want to enhance and expand the team's capacity to effectively collaborate to address the needs of infants, young children, and their family caregivers affected by substance use disorders and prenatal substance exposure. Again, we have indicated the importance of collaboration because we do know we have data that proves that working as teams is more effective for families and children. Sustainability. We want to sustain the effective collaborative partnerships, processes, programs, and procedures implemented to achieve the goals of each demonstration site. And then lastly, dissemination. We want to be able to provide the field with lessons they can apply about effective practices for implementing the requirements of CARA and meeting the needs of children and families affected by substance use disorders. So our quick target groups. Obviously, the target population would be those infants, young children, and their families or caregivers affected by prenatal substance exposure and substance use disorders that the collaborative community court teams will serve. Our technical assistance targets would be those selected teams and their partner agencies, including child welfare, substance use disorder, and mental health treatment agencies, healthcare providers, and other relevant child and family serving agencies. And again, our dissemination targets would be the larger field of collaborative problem-solving courts and their system partners across the country. So I hope this information has been helpful in giving you some background on the Quality Improvement Center. And now I will turn it over to Ken to go into more detail regarding technical assistance and background regarding children and family futures. Ken?
Thank you, Tracy. So I want to take a few minutes to talk about the technical assistance team background and approach. In other words, I want to introduce you to the team behind the team. We're proud of the team we've put together to assist demonstration sites to strengthen services and improve outcomes for infants with prenatal exposure and their families or caregivers. So a little bit about the Center for Children and Family Futures. As I mentioned, we're the lead agency for the QIC, and I just want to highlight a couple of things in terms of our background and work. You see on the left-hand side of the slide, Office of Juvenile Justice and Delinquency Prevention. We're the National Training and Technical Assistance Program for Family Drug Courts. I work with SAMHSA grantees as well as OJJDP Family Drug Court grantees. We're working with 5 states on behalf of OJJDP to implement statewide system improvement that involves either the expansion of family drug courts or the infusion of core family drug court processes into dependency courts. Our Prevention and Family Recovery Program is funded by the Duke Endowment and the Doris Duke Charitable Foundation. We're currently working with 4 family drug courts to implement parent-child evidence-based interventions and to strengthen their services for children as part of their family drug courts. And on the right-hand side of the slide, you see the National Center on Substance Abuse and Child Welfare that the Center for Children and Family Futures has been operating since 2002. And under that program, that I should say that the National Center is funded jointly by SAMHSA, the Substance Abuse and Mental Health Services Administration, as well as the Children's Bureau. And under that program, we have been the programmatic technical assistance provider for all 4 rounds of the regional partnership grantees, which are almost up to 100 grantees that have been funded by the Children's Bureau since 2007. And then we've operated an in-depth technical assistance program since 2004, where we work with states across both child welfare, the court system, and substance use disorder prevention and treatment systems to strengthen their collaborative practice in order to improve outcomes, provide better access to services for families with substance use disorders in the child welfare system. Since 2014, our in-depth technical assistance program has been focused around the issue of substance-exposed infants, and as Tracy just mentioned, the impact in helping states and communities address the impact of opioid use disorders and everything related to that, including overdose deaths and the impact on infants, the increases in infants born with prenatal exposure, with neonatal abstinence syndrome, and certainly the impact the opioid epidemic has had on the child welfare system. Quickly, project staffing, introduce you to the subcontractors and consulting organizations that will be part of the QIC technical assistance team. And I'll highlight some of the activities and relevant work that they've been doing next. And you see on this slide, Nancy Young is the QIC project director, and I'm working for Nancy as the deputy project director. So the expertise that those contractors bring to the QIC. The Advocates for Human Potential out of Boston, who was the evaluator, as I mentioned a few minutes ago, for the QIC. The National Center for State Courts, Tribal Law and Policy Institute, the American Bar Association, the Center on Children and the Law, and subject matter experts. And you got a glimpse of those subject matter experts in the previous slide. Those experts include areas of the expertise that those experts bring to the QIC includes areas of developmental pediatrics, early intervention service, child and family judicial practices, and court training and legal representation. The relevant work from our partner organizations, and I'll highlight these really quickly so you can see for the National Center for State Courts, they are the Capacity Building Center for Courts and several other initiatives that they've been working with dependency courts, as well as addressing the opioid epidemic and the impact on the judicial system. Advocates for Human Potential has done multiple evaluations related to the regional partnership grant and behavioral health, as well as the integration of treatment services with child welfare. And the principal author of the Moms Do Care evaluation. Slight hesitation on the slides, bear with me. The Tribal Law and Policy Institute, we're real excited that they're able to join this partnership. Just published Tribal Healing to Wellness Courts Treatment Guidelines, the 2nd edition. TLPI is also the Capacity Building Center for tribes, and will be assisting us as the partner agencies, as well as the demonstration sites with and tribal courts with serving serving Native populations, as well as assisting tribal courts with the implementation of the QIC. Should they be selected as a demonstration site. And then the American Bar Association Center on Children and the Law. They are the lead organization for the Capacity Building Center for Courts, and you can see the other initiatives that they're involved in: the National Alliance for Parent Representation, Family Justice Initiative, and Child Law Practice Online. Our TA approach is built on a foundation of establishing a trusting relationship with sites over an extended engagement. The anticipated duration of the length of engagement with demonstration sites would be 30 months, and you'll see in a few minutes the time frame for selecting sites. These next few slides will highlight our approach to providing technical assistance and engaging demonstration sites. The Quick Change team, highlighted here, includes staff from our partner organizations. The intensive training and technical assistance from the dedicated change team will support the design and implementation and testing of approaches. Recall one of the intents that Tracy just mentioned around testing approaches for the implementation of Comprehensive Addiction and Recovery Act amendments to CAPTA. The change team will include 2 senior-level change liaisons, one from the Center for Children and Family Futures and one from the National Center for State Courts, who are highly experienced in collaborative practice. Staff from TLPI and the Center on Children and the Law will also participate in the change team, will be involved in the review of proposals, and will be able to bring their expertise and consultation to the team as well as to the demonstration sites. And the change team, as well as the demonstration sites, are supported by advocates for human potential evaluators or evaluation liaisons who will be assigned to work with each site, both in terms of the evaluation as well as helping sites with a continuous quality improvement approach to process and outcomes evaluation and building demonstration sites performance monitoring capacity. And then we've got access to the expert consultant pool and subject matter experts on an as-needed basis to provide content and subject expertise to all the demonstration sites. These next couple of slides highlight the frameworks that has guided our work at the Center for Children and Family Futures and guided much of our technical assistance approaches, working across child welfare, substance use disorder, treatment systems, the judicial system, and in the last several years, infant and maternal child health care providers and hospitals. We've developed these frameworks over many years, working with family drug court collaborative teams and state and local collaborative partnerships that are broader than just family drug courts. So you see in this slide 10 essential components of collaborative courts that essentially were developed as a result of our work with family drug courts. The system-wide approach that's illustrated in this slide is designed to strengthen collaborative practice and improve both short-term and long-term outcomes, and assist with the information exchange and measurement of the effect of collaborative initiatives. Looking at the graphic from the bottom moving up, shared mission and vision is really the foundation for collaborative courts. And collaborative court teams must have a shared mission and vision to define their joint work. While each partner system might have a mission specific to their role and to their agency, the team mission and vision statement elevates the partner's work to a higher collaborative goal, and that is hopefully strengthening services and improving outcomes for children and families. The next, moving up in the slide, you see agency collaboration, and these domains provide the systems infrastructure needed to implement and sustain policy and practice changes. And that includes interagency partnerships. It includes interagency partnerships, information sharing both at a client, family, and child-specific level as well as on a systems level, cross-systems knowledge, often involving cross-systems training about the partner systems involved in the collaboration, and then funding and sustainability. How can practice and policy changes and the processes of a collaborative court team be sustained after either grant money or seed money, or in this case, demonstration site support expires. The client services, the agency collaboration then provides support for the client supports and the client services, the direct services, if you will, to families, and that includes early identification and assessment, the service needs of both adults and children, and the approaches of a family-centered services to adults and children. All too often, historically, we've seen many of our systems bifurcated between adults and children, and we really want to work with communities to take a look at their capacity for family-centered substance use disorder treatment and really integrate services to adults and children on behalf of families. And then community support services that will support families that are available in the community after completing or leaving a collaborative court team, and certainly after the completion or leaving services that are provided through an engagement process. And then shared outcomes. Collaborative court teams must demonstrate that they've achieved desired results as defined across partner agencies, agreeing on goals and establishing performance measures to ensure joint accountability. All right, here's the next framework. This framework that we call the Policy and Practice Framework for Prenatal Substance Exposure, 5 points of intervention for children and families, really first appeared in a SAMHSA publication called Substance Exposed Infants, State Responses to the Problem, back in 2009. It's guided our technical assistance work to prevent and respond to prenatal substance exposure, infants affected by prenatal exposure, and the service needs of parents and caregivers and their capacity to care for infants and children affected by prenatal exposure. It's also included in ONDCP's drug control strategy. So you look on the left-hand side of this slide, addresses both, beginning with pre-pregnancy at the top of the slide, then addresses both the processes and needs for infants, for parents, for women prenatally, and the opportunity for screening and assessment, and in certain situations, linkages to services, particularly substance use disorder treatment services that could mitigate the exposure of a neonate, if you will, to substances prior to birth, and then identification at birth, which is where CAPTA and kicks in the 2016 amendments, identification of infants at birth who may have been prenatally exposed, and then the services that both mom and infant might need postpartum, and then children developmentally in infancy and beyond, and then just integrate services for parents as well. And so you see the family-centered approach manifested in this slide. That as we address the needs of infants at birth and prenatally, we're also integrating and addressing the needs of parents and caregivers in order to address their service needs if they have a substance use disorder, and make those linkages as well. A little bit about demonstration site engagement. This is what you can expect from the technical assistance change team. Just a few minutes ago, I spoke of building a relationship with sites. So some of you are interested in the level of effort from your end. This in some ways crosses over the level of effort from our end as a change team and change liaisons, and then your participation in these activities. So we envision monthly site calls is how we work with sites. Oftentimes that involves the court team, and then separate calls with project directors. And of course we'll work with all the demonstration sites, depending on the structure and the frequency of their court team meetings, but certainly at least monthly calls with the change liaisons and the project director. And then on-site technical assistance and annual site visits. This helps us in our initial site visit understand your program, understand the context in which your court is operating, understanding the context of your partner agencies and what's going on in your community, and helping us and you identify technical assistance needs, and lays the foundation on the initial site visit for developing a site plan and begin to lay out what targets are for policy and practice changes and action steps in order to accomplish them. In the first year of the participation in the QIC, there will be an all-sites meeting held in Southern California, and this says annual, but actually the all-sites meeting is only planned for the first year of the initiative. And then we want to provide distance learning webinars bi-monthly, and there's a couple of approaches, or I should say content, in which we do this. So early on, we'll bring to you the expertise from the QIC and the consulting organizations or contracting partners that I discussed earlier, as well as expertise from the subject matter experts. As your programs develop, we want to also facilitate a learning exchange using these distance learning webinars, giving you the opportunity to share your goals, your action steps, the challenges you're having with implementation, be able to brainstorm that with colleagues, with other demonstration sites, and take advantage of of the community, if you will, of quick demonstration sites, and learn from each other as you develop, as you implement strategies under the QUIC initiative. And with that, I'd like to turn it over to Dr. Terry Tobin, the Director of the Center for Research and Evaluation at AHP, to talk a little bit about evaluation under the QUIC. Terry?
Thank you, Ken. Hi, everyone. As Ken mentioned, I'm Terry Tobin from AHP, and I'm leading our team in conducting the evaluation component of this project. I'm going to take the next few minutes really just to give a brief high-level overview of the evaluation and walk through. We designed it with a few key features that are listed here, and walk through those. So first of all, it's all built on a strong conceptual framework. We have integrated formative process and outcome components to it that will allow us to really get into studying implementation at the demonstration sites, learn about the services and activities that are part of each site, and identify and share innovative models, strategies, barriers, and lessons for everybody to learn from. It includes also an evaluability assessment where we'll work to look at each site's capacity to collect and submit the data specified in the evaluation plan, and we'll use those results from the assessment to finalize the plan and be able to provide TA to the sites to support it, for everybody to be able to participate. It includes a mixed methods approach, and by that we mean we use both qualitative and quantitative methods and analyses that allow us to do a couple things. By combining those mixed methods, we're able to make sure that we systematically collect data across the sites, which is important, but it also allows us to have a more nuanced exploration of site-specific activities. So it lets us cover both of those pieces. It's a multi-level design that collects data from all the different perspectives of those implementing your projects. As we know, there are lots of folks involved, and we want to get at capturing the perspectives of everybody. We'll also maximize the use of existing data. We'll work with the Children's Bureau and with the sites to identify existing data, secondary data sources, secure data sharing agreements to be able to make that data flow, and work with you to secure data transfer protocols and get all of that squared away so that we can really take advantage of the wealth of data that already exists and learn from it. We'll also, with all of this data, use an analysis plan that helps us account for the complexity of studying 15 different sites, which will have both common and unique goals, and a wide range of contextual environments in which you're implementing your projects. So the analysis plan has to allow us to take all of that into account. And then finally, as Ken mentioned earlier, data-driven CQI reporting. This lets us capitalize on opportunities to really inform the feasibility, utility, and sustainability of all of the site's efforts. And I'll talk a little bit more about that on the next slide. When we talk about CQI, we're really talking about evaluation supporting a continuous loop, a cycle, where we'll share the findings that emerge from the data collection and analysis that I just talked about. Those findings then can be used to make adjustments as you get the data back. And then we'll assess the impact of those adjustments and keep feeding the results back as we go along. So it all loops around again and again as we learn from the data being collected. I think that covers it for the evaluation. So I'll turn it back to Ken. He's going to talk more about this opportunity in the application process.
Thanks, Terry. So these next slides are kind of a high level, some detail, the nuts and bolts of the application and site selection process, which I'm sure is of particular interest and probably the reason why you're on the call today. We'll highlight some of the content that will also be included in the RFP. So the demonstration site opportunity and the eligible applicants, there will be 15 demonstration sites, and the demonstration sites will be court teams. But as you can see, there are several options for whom the lead agency or the applicant agency can be. And I'll try to make these clear for you all, and then we'll also lay them out in the RFP. So this first pathway allows state or tribal court improvement programs or tribal governments who might not have, and the majority of tribal governments don't have CIPs, would allow them to be eligible to submit an application in collaboration with up to 3 local courts. So again, the applicant agency would be state or tribal CIPs or tribal government. If the tribe does not have a court improvement program, the tribal government or an agency the tribal government designates as a lead agency could submit an application in collaboration with tribal courts. Really what we're saying here is that a state or tribal leadership entity like a tribal government or a court improvement program could work with courts within their jurisdiction to submit an application, and we're suggesting up to 3 courts in a particular state or tribe work with those courts in submitting a proposal and application to become quick demonstration sites. So each of those, let's take the example, if a state or tribal government, CIP or government submits an application for 3 courts, and those 3 courts are selected as demonstration sites, that would count as 3 demonstration sites. The second pathway allows local courts, tribal courts, or other community-based agencies who may be partners with the local court, allows them to apply directly as a demonstration site if, in those situations where a state court improvement program or a tribal court improvement program or tribal government elects not to submit an application as a lead agency. So if you're in a state and the state CIP is not able to submit an application as a lead agency, or tribal CIP or tribal government is not able to submit an application, then in those jurisdictions, local courts, tribal courts, or community-based agencies could then be the applicant to be a demonstration site as a collaborative community court team. This 2-pathway approach, we think, ensures the engagement of state and tribal CIPs. So if if a local court submits an application as a lead agency, we would also expect letters of commitment from the state CIP or tribal CIP or tribal government. So we want the connectivity between local implementation and state leadership or tribal leadership. As Tracy mentioned a few minutes ago, one of the goals of the QIC is dissemination to other courts and to be able to disseminate and take the lessons learned as well as successful implementation strategies from the 15 demonstrations and share those with other courts, both within a state jurisdiction or within a tribe, as well as across other states. And so the role of both tribal governments and state and tribal CIPs, either as applicant agencies or as agencies that are supporting and committed to the work of the local courts, should those local courts apply as demonstration sites under the second pathway. Okay, now we can move forward. So there'll be 15 demonstration sites, and the engagement with demonstration sites will last through September 2020. The site selection process will be completed, is scheduled to be completed by the end of March. So that's about a 30-month engagement. The QIC will execute mutually binding agreements with the applicant agency. Think about the pathways that I just mentioned. And that mutually binding agreement would include the responsibilities of the demonstration sites and the QIC, us as the QIC entity, as well as agreement on how the funds, the funding allocation of $70,000 annually per demonstration site, how those funds are to be utilized. And you see some examples here of how these funds can be utilized that we put together. And these are not final, but will give you an idea of what we're thinking about and what the Children's Bureau is thinking about in terms of the allowable use of these funds. Certainly travel and per diem for the all-sites meeting that I mentioned previously that would be held in Orange County, California. We don't have a date for that yet. We're making sure that we don't conflict with other Children's Bureau meetings or grantee discretionary meetings that might occur early in the summer. Staff training on evidence-based parent-child interventions, developmental or other therapeutic services for children, a court coordinator or plan of safe care coordinator. And that parentheses is pretty important, that the funds can't be used to supplant the existing funding. A word about plan of safe care coordinators. Again, one of the intents of the QIC is to assist jurisdictions with implementing CAPTA. Excuse me. And in our, we've been working with, we've probably worked with over 10 states right now, and in the last 3 years, in implementing plans of safe care and addressing the requirements for CAPTA for infants affected by prenatal exposure. The plan of safe care coordinator can be responsible, we seem to be responsible for developing plans of safe care and coordinating the services for an infant and family upon discharge from a hospital. Some jurisdictions are able to implement that coordination during the prenatal period. Plan of safe care coordinators could also function as a navigator or liaison across the various systems, including hospitals and infants and women's health care providers. You may have case managers. Existing courts may already have case managers, and so those functions could also be assumed there as well. And then part of this funding could be used for evaluation support. One of the questions that has come up previously was, well, if under Pathway 1, state CIP or tribal CIP or tribal government is the applicant, would any funds be available to them? This is the allocation per site, so we would work with the CIP or tribal government or tribal CIP, work with them, and as well as the demonstration sites that will be selected in those jurisdictions to kind of work through the execution of the mutually binding agreement that would allow, depending on need and depending on what funds would be used for, to support some of the work of a Pathway 1 applicant agency. But bear in mind that this is the total allocation per site, and so we would have to, you would have to work that out with your local demonstration sites, and we would work that out with you under the mutually binding agreement. We're planning on releasing the request for proposal in mid-January, and applicants will have 30 days to respond to the RFP. We're hoping, we want to keep this to a 7-page narrative, and that makes it real challenging. I think we've all been involved in writing proposals where there are page limits, and to address the elements, the anticipated elements in the request for proposal, require some succinct writing and kind of to the point writing narrative about what each site plans to do as a quick demonstration site. After the applications are submitted, we'll convene a team from the QIC partners. Every application will be assigned to the change team, and each member of the change team will conduct a review of the application. We'll score those applications. Applications with the strongest proposals will then be invited to participate in an individual conference call, hour long, maybe it might go a little longer, but really to discuss your proposal and as well as discuss project expectations to make sure you understand what is expected as a demonstration site, but also answer any questions about the work that we're doing as to QIC and clarifications that you might need from us, as well as clarifications that we might need from you. The final selection is slated to take place by the end of March, and will take into account the results of your application, the results of the review of your application, as well as some other points here and some other considerations, such as the level of need that you illustrate and demonstrate in your application, geographic distribution of applicants, and the cultural diversity of the target populations. The QIC team will consult with Tracy Watkins and the Children's Bureau in making the final selection of demonstration sites. Successful applicants will demonstrate, and this will be outlined in a bit more detail in the request for a proposal, but will demonstrate need, readiness, and commitment to the QIC initiative. The 30-month duration is not a long period of time to implement practice changes to address the needs of infants and families, and particularly implement the CARE amendments to CAPTA. We worked with our first round of in-depth technical assistance sites for 3 years, and they're still working on statewide implementation of CAPTA. Court teams do not have to be established to be an eligible applicant. So if teams are forming, so your proposal can include a planned court team. In other words, we're going to propose a court team. So we wanted to make sure that the application process was open to not only established court teams, whether they be infant toddler courts, whether they be family drug courts, whether they be other collaborative courts like an early childhood court, but we also wanted to make sure that the application process was open to teams that may be coming together for the purposes of participating as a demonstration site and to address these issues with infants and families. But in either scenario, in either situation, it's important that the applicant have buy-in from leadership of their respective agencies and leadership from the applicant agency to support this work, as it very well may, and we certainly expect it to include practice changes in serving infant families. These are some examples of what we mean by demonstrating need, and these need bullets only highlight examples of potential need in your jurisdiction. The RFP will describe in more detail what this means, but we'll also include domains or issues such as current trends, concerns in your jurisdiction as it relates to infants with prenatal exposure. We'll ask you to describe how these needs have affected the various systems in your jurisdiction using both recent data and other available information from the kind of the core partner systems, if you will. We know that this epidemic has had a tremendous impact on communities, certainly on families, as well as has taxed child welfare system, substance use disorder treatment system, the healthcare system, and including the hospital system. So I'm not going to go through lots of questions now, but the RFP will lay out and provide guidance on the type of the kind of content that can demonstrate need both in the child welfare system, such as there has been an increase in number of infants with prenatal exposure. Has there been an increase in number of infants removed in and out of home care? And we know that nationally there have been substantial increases in the number of children removed from their homes. And under most reports, they're not scientifically demonstrated yet, but under most reports driven in large part by the opioid epidemic. challenges in the treatment system and needs in the treatment system. Is an increased demand for treatment for pregnant women? How about a waiting list? Is there a waiting list for women to enter treatment? What's the availability of evidence-based, culturally relevant treatment for women with infants and children, and the availability of medication-assisted treatment? And what's the need and the impact been on hospitals? Increases in the number of infants born with NAS, increases in the length of stay and the associated costs for babies affected by and identified as having prenatal substance exposure or neonatal abstinence syndrome. When we talk about readiness, we're talking about these domains: team composition, how is your court organized, what's your governance structure, and what's the membership of your core team. In talking about collaboration, what collaborative processes are in place that support partner agencies working collaboratively to strengthen services for infants, children, and families? How is information shared across systems? How have you dealt with issues of confidentiality? Capital implementation is a challenge for many states and many jurisdictions, and several states are a little further down the road in implementing those components of CAPTA that includes identifying infants affected by prenatal exposure and identifying those infants at birth, notifying child protective services of those infants through a notification process that may or may not be different from an abuse report, and then developing plans of safe care for infants, young children, and their parents or caregivers affected by substance abuse and substance use. This work, the CAPTA implementation, will really need to be coordinated with the implementation that's occurring within your state or within your tribe. A couple questions have come in around program improvement plans from the Children's Bureau. And yes, this work can certainly enhance strategies that might be important or included in your program improvement plan under CAPTA. I also want to say that I recognize that I think for tribes, the federal legislation for CAPTA doesn't apply to tribes. To my understanding, tribes are not receiving CAPTA block grant funds. However, we're working with a number of tribes under in-depth technical assistance where they are implementing plans of safe care, and it's not because it's obviously not a statutory requirement for tribes, but it's good care. It's a good approach for assisting and supporting moms and infants and young children who are affected by prenatal exposure, affected by different not only opioids, but methamphetamine and other substances. So tribes are looking at how they can implement plans of safe care as good practice in order to help keep families together and in order to interrupt the cycle of abuse and neglect and addiction. And then under evaluation, what formal agreements, practices, or policies or protocols in place to share data across systems at both individual client family level as well as an aggregate level. Can you report baseline data on the prevalence of families affected by substance use disorders, parents involved in child welfare system, receiving substance use disorder treatment services, pregnant women being served, etc. Recall I said this several times, recall there are two specific areas of intent under the QIC, right? To specifically address the needs of infants, young children, and their parents or caregivers affected by substance use disorders, and to design, implement, and test approaches to meet the requirements of CAPTA. Right, so in order to do that, in order to effectively do that, really requires a commitment from the partner agencies and a commitment from the applicant agency. As I talked about several slides back about the importance of mission and vision laying the foundation for this work. And the team's mission statement really should reflect the intent of what the court team wants to achieve. What will be different about how you serve infants, children, and families as a result of this work, and commitment to system improvements and changes. And that includes, that it really includes that if effective practices are identified as a result of this work, is there a commitment from leadership to infuse effective practices in the broader system, let's say outside of a particular court, in other courts, as well as how these agencies and how partner agencies work collaboratively. Letters of commitment are not the same as letters of support. These letters, we expect to describe the agency's commitment to participate, contributions to the initiative, and willingness to engage in system and practice improvements. I want to just recap a couple of things on this next slide before we take a look at questions that may have come in. So we're putting together the questions and answers from both webinars, the one we're doing today and the one we did last week. A number of questions have come in as part of the registration process, as well as questions have been submitted during these webinars. We'll put those together in a Q&A, and then once they're approved by Tracy, we will post them on the QIC website, which you see in that final bullet there on the bottom bullet. And we'll also give a notice out to all the registrants that the questions and answers will be posted at that time. Should you have additional questions, today's not your last and only opportunity to submit questions to the QIC, to us. You can send your inquiries via email to that address in the second bullet. And again, if it's questions about the RFP, we'll incorporate those as well into the webinar questions and answers. And we'll probably have to update that from time to time based on the questions that come in. Again, to summarize the kind of the next steps, RFP release sometime in mid-January, 30-day response time on the part of applicants, then the teleconference consult and assessment, and we hope to complete final selection in March of 2018, and then sometime in the summer of 2018, an all-sites meeting in Orange County, California. Let me stop there and see if any questions have come in during the webinar before we take a look at some of the resources that might be available to you. Akshay?
Hey, Ken. We actually do not have any questions at this time. So if anybody has questions, please feel free to use the chat function on the right side of the screen. Thanks.
Okay, thanks. Let me hit a couple of the resources available to you, and if you have trouble accessing these, then you can give us an email to the address that was posted on the previous slide. This is a publication that was published through SAMHSA and Children's Bureau. Came out in August, September of 2016. You see it's a collaborative approach to the treatment of pregnant women with opioid use disorders. It has many of the foundations, including the 5-point intervention framework, and really almost a step-by-step approach for forming collaboratives to address the challenge of working with families with substance use disorders, and particularly the challenges of working with infants and the healthcare system in addressing the needs of infants, children, and families. And you can see the practice policy considerations are targeted to child welfare and collaborating medical and service providers. And you see on the bottom of that slide how you can access that with the web link is through the National Center on Substance Abuse and Child Welfare through the SAMHSA website. Additional resources on opioids that we've collected related to the collaborative guidance document and our work with sites, and we also try to pull in site examples from states around what they're doing around this work, and as well as examples around the implementation of CAPTA and the requirements of that were embedded going back to 2003 in CAPTA, but amended in 2016 under CARA. If you're not familiar with these Children's Bureau policy resources, and you see the links here, Child Welfare Policy Manual, as well as information memoranda and program instructions that address CAPTA and address the part of CAPTA specifically around infants with affected by substance use disorders, affected by prenatal exposure, guidance to states in completing their annual program and service reports, as well as some suggestions, some highlighting some best practices, and I know the Children's Bureau has been reviewing the state submissions of annual progress and service reports as it relates to infants with substance use disorders. Contact information for Dr. Young and I, and let me see if, Tracy, do you have any final words that you'd like to impart?
Only that I hope this information has been helpful to everyone. Again, as Ken has indicated, if you have questions, please use the email address, and we look forward to your creative proposals. And I think that's all that I have.
Thank you, Tracy. Thank you. We appreciate your time today. We really hope that you will give serious consideration to submitting a proposal once the RFP comes out. We look forward to the opportunity to work with 15 demonstration sites, with your local teams, as well as with your tribal governments and tribal and state CIP offices. If you have any questions about anything we've talked about today, again, you can send us the emails on the slides. We will post this webinar, the recording with the slides, in the near future. I'd like to say the next couple of days, but I won't say that because I'm not 100% sure that it'll be ready. But we'll send a notice out to all the registrants when the webinar is available. Please feel free to share this with your partners that may not have been available today. We realize this is a challenging time, the week before Christmas, and certainly any of your partners or state agencies will be able to go in and view the webinar if they weren't able to make it today. So with that, we wish you well for a blessed, restful, and peaceful holiday season, and hope that you all have quality time with your families and some downtime to just share with your families and loved ones. We thank you for your time today and look forward to working with you. So long.